So good evening, sir. Good evening to one and all. I first of all thank the Indian College of Anesthesiologists for giving us the opportunity to be part of this great program, which has been running for like 158 episodes today. It's a great achievement for this college. I've been regularly participating in this event. I thank Dr. BRK sir, Dr. Sree madam, and many senior members who have been a pillar for this Indian College of Anesthesiologists. Today, we are discussing about the positions in anesthesia. I consider positioning in anesthesia as a basic fundamental for every anesthesiologist. We have been taught a lot in the pre-operative anesthesia assessment about the airway, about the cardiovascular functions, but little has been emphasized about what the patient is being positioned, how they are going to position. So if you look at the surgeon's manual, so a lot of importance has been given to the positioning so that they achieve the best optimum results, best optimum surgical exposure. But there is least importance is given in the pre-anesthetic assessment, also as well as the intraoperative checklist, and how do you monitor the position in the intraoperative period. So as a neuroanesthesiologist, myself and my team have been regularly conducting anesthesia for various neurosurgical procedures in different positions day in and day out. However, these positions are also relatively important in other general surgical practice, thoracic surgery, and other areas of interest. So today, even though the speakers are from the neuroanesthesiology background, there is a touch of every part of surgery, like thoracic surgery, then lithotomy position, and various aspects which anesthesiologists should be aware of during the proceeding. To moderate the session, I would like to welcome Dr. Jeeva George, who is at present the senior specialist at Caritas Hospital in Neuroanesthesia and Neurocritical Care at Caritas Hospital, Kottayam. She did a post-graduation from CMC Ludhiana, and she did a DM Neuroanesthesia from SCTIMST Trivandrum. Welcome, Dr. Jeeva George. For this today's program, we have divided this. There are 4 good budding neuroanesthesiologists who are present in our department, who are very versatile speakers, which we have come across for last 2 or 3 years. So we have divided the positioning into commonly used position like supine position, prone position, lateral position, and sitting position. For this today's session, first I would like to call Dr. Aswin Ram, who has just joined the DM Neuroanesthesia. He did his MD course from PGH Chandigarh. I would like to welcome Dr. Aswin Ram for the supine position and modifications and what care should be taken. Dr. Aswin, please.
Thank you, sir. Now I will take over. Good evening to everyone who is watching the webinar. I am Dr. Aswin Ram, who is currently a first year DM Neuroanesthesia resident at Trivandrum Institute, Trivandrum. First of all, I would like to extend my deepest gratitude to the members of ICA and also to our professor in charge, Dr. Manikandan sir, for providing this opportunity to speak about this topic. So today, I was speaking about supine positioning and anesthesia. So today we'll be dealing on 4 topics: the physiological changes that occur in supine position, the supine positioning itself, how to position, and various complications and variations of supine position. So first, let's go ahead with the topic. So first, we'll deal with the physiological changes that occur in the supine position. So as you can see in the box, these are the changes that occur. This is in comparison to a person who is upright and awake. And these changes occur in the patient who is lying supine and is anesthetic. Coming to the cardiovascular changes, first, when the patient lies supine, there is automatically an increased venous return, which increases the stroke volume and the cardiac output. The heart rate is reduced. The systemic vascular resistance is also reduced. The systolic blood pressure and mean arterial pressure more or less remain the same. And in the lungs, what happens is the patient when the lies supine, the diaphragm is pushed up, and also the posterior part of the lung, the dependent lung zones, they are the lateral gases. So this all leads to reduction in the FRC and reduction in the total lung capacity also. So this leads to a ventilation perfusion mismatch, which should be taken care of. Coming to the central nervous system, what happens is the surface suction pressure can either be normal or it can be reduced. States of drainage may also be impaired in these patients. So we need to be careful of it. So as you see from the picture, this is the supine position, also called as a dorsal decubitus position. The patient lies on the back, the head, neck, and spine are all in a neutral position, and a small pillow is placed beneath the head. Legs should be extended and should not cross each other. Spinal column and should be in alignment with the legs parallel to the overhead. Head also should be in line with the spine. Hips also are parallel to the spine. Adequate padding must be placed under the head, arms, and the heels, and also preferably pillow should be placed under the knees. A safety belt should preferably be placed above the knees so that it does not impede any circulation. Coming to the arm position can either be abducted or adducted, or one arm can be adducted and another arm can be abducted, however the surgery requires. And hand and forearm should be supinated in the neutral position, and palm should be towards the body. And whenever we do abduction, abduction should be limited to less than 90 degrees to avoid stretching of the brachial plexus. And when a patient's arms are abducted, usually they should be held alongside the body with a draw sheet. So the draw sheet, how it should be done is it should be passed over the arm and under the body, and it should tuck under the torso and not under the mattress of the table. This is to ensure that the arms do not fall off. Some places also use straps. Straps can also be used. And also elbows, any protruding objects like IV fluid lines, stopcocks, they should be padded so that they don't impinge on the patient's body. And also there should be no skin to metal contact because electrical burns can occur if pottery is being used if there's not proper grounding or some issues happen. And excuse me. Sorry about that. And this picture here shows the pressure points. These pressure points should be adequately padded. As shown here in the occiput, there should be a soft padding, and the scapula should also be protected. The sacrum and coccyx should be protected. A pillow should be placed under the knees. And here in Chitra, we use gel pads to protect the calcaneus. Or we can use other like another pillow also, as a small pillow also can be used. And head position. Usually supine position, the head is neutral. It can be neutral also, or it can be flexed, extended, or turned to the counter. Since we are dealing with neuro cases, these are the different surgeries in which the head can be placed. It will be dealt with in future presentation, the next presentation. Coming to the complications of supine positioning, so there can be pressure alopecia, pressure point injuries, backache, and nerve injuries. So we first will talk about nerve injuries. Nerve injuries, they occur either because of compression or because of undue stretching of the nerves. Compression can occur due to either direct compression or whenever a vessel is compressed, and that then leads to ischemic neuropathy. So we'll see ulnar. Ulnar is the most common nerve injury in patients, and it's most common in supine position also. It occurs when the nerves compress between the posterior elbow and armboard or bed. More likely when the elbow is flexed or forearm is pronated. So to avoid such injuries, the elbow flexion should be minimized and the forearm is ideally supinated. So post-op, the patient can develop loss of sensation in the rear portion of the hand and indicate the adductor or opposite of the finger, which is a feature of ulnar nerve palsy. It's called as claw hand. And coming to brachial plexus injury, since it has a superficial force from the neck all the way to the shoulder, is also very liable to injury. It can occur when the armboards are abducted beyond 90 degrees, causing undue stretching of the brachial plexus. Whenever the armboards are higher or lower than the OT bed, as I'll show you here, as shown in this picture, because the arm board is lower in the OT bed, it is getting unduly stretched and it can lead to nerve injury. Also, lateral rotation of the patient's head away from the injury site, again leading to stretching of the brachial plexus and injury. Or when the anesthetist leans against the shoulder or arm, or we use shoulder braces. We see in tendon position. Shoulder braces are pushed against the shoulder, which can compress the brachial plexus directly and cause injury. So these things should be avoided, and adequate padding should be present. Also, when excessively tight arm restraints in the forearm, it can compress the anterior on the vessel that supplies it. This can lead to ischemic neuropathy, so it should not be very tight, it should be a bit loose. And coming to the peroneal nerve, common peroneal nerve can be damaged because of other direct compression. Especially it's seen in patients who are extremely thin because the nerve is superficial and it can be compressed on the bone and the OT table. Also, a hyperextension of the knees, again the nerve gets stretched, leading to injury. Any direct pressure behind the knee, or we have a gradual compression process that are too tight, it can lead to peroneal injuries. So all of these things to be avoided. Again, adequate padding is of the utmost importance. We'll talk about the variations of supine positioning. First, coming to the launch chair position. So the launch chair position, basically the hip is flexed. As I said, the trunk and the thigh, there's an angle of around 15 degrees. And the thigh and the knee hinge is also angled in a similar amount in the opposite direction. This can be achieved using the OT table itself, or it can be achieved by using a roll towel or a blanket placed beneath the patient's knees to keep them flexed. So flexion of the hips and the knee helps decrease tension on the back. So this can potentially lower the back pain also. As you can see the pictures here, this is how you position a patient for launcher using an OT table. So first in A, the OT table is supine. In B, first what we do is we flex the hips. And in C, we flex the knees as shown by the lower end of the table is flexed. And finally, in D, we bring the table back into the level zone. And this achieves the launcher position. So advantage of this is it is better tolerated in an awake patient whenever you do MAC anesthesia. And venous drainage in the lower extremities is also enhanced. Also, the distance between the xiphoid and the pubic area is reduced, which helps in easy closure of laparotomy incisions. Coming to Trivandrum position, so others called head-down position. So here the overbed is modified such as the held-down tilt of 15 to 20 degrees is done. It results in the head being lower than the pelvis. Arms can be in a comfortable position, either they are adducted or can be abducted on bilateral arm boards. It is generally used in lower abdomen surgeries, pelvis, and genital system because the tenable position helps push the abdominal viscera away from the pelvis. So whenever tenable position is there, there's a risk of the patient falling off. So there should be proper techniques to restrain the patient. One we can use is anti-skid bedding, or the knees can be flexed, or we can use shoulder braces, or we can use padded cross dorsal straps. Nowadays, shoulder braces are not recommended because, as I said before, they can compress the brachial plexus directly, and they can lead to brachial plexus injury. This is the picture denoting on the left side, you can see there are shoulder braces are being used. On the right side, the knees are flexed so as to prevent the patient from falling off. And see what change that occur during tenable position is there is an increased CVP, cerebral venous pressure, due to increased venous return. Intracranial pressure also increases. Intra-auricular pressure can increase. It can also increase the myocardial work. And FRC is reduced due to gravitational pull of damping, that's cephalad. So these changes must be kept in mind whenever the patient is in a tenable position. And also, prolonged head-on tenable position can lead to swelling of the face, conjunctiva, larynx, and the tongue. So whenever we want to extubate these patients, we should be very careful. So that you should check for the there's no edema, and maybe we can even ventilate the patient and then extubate the patient. It is usually contraindicated in patients with raised ICP and also in pregnant females. The advantage of the tenable position is it improves exposure, as said before, in lower abdominal and laparoscopic surgeries. And post GA, if there is a hypotension, they can use the tenable position It will temporarily increase the venous return and you can correct the hypotension. Also, we can use it in center line placement because it increases cerebral venous pressure. It increases the filling of the artery and they become more prominent. Steep head-on surgeries are now used for robotic surgeries, robotic prostate surgery and gynecological surgeries. Coming to the reverse Trivandrum position, this is the opposite of the Trivandrum position. Here, what happens is the head is above the level of the pelvis. So venous return is reduced due to peripheral pooling of limbs. This can lead to hypotension. Lung volume is increased however due to coronal movement of the abdominal viscera. This can lead to cerebral perfusion also. So should be careful. So said before, the entire OT bed is tilted, so the head is higher than the feet. It is generally used for head and neck and laparoscopic procedures, like especially lap cholecystectomy. It helps in facilitating the exposure, decreases blood supply to the area, especially in head and neck surgeries, and provides a bloodless field. In this patient, the padded footboard is used to prevent the patient from sliding towards the foot. Next, coming to lithotic positions, there are various variations of lithotic position. The standard, high, low, and exaggerated. We'll see each one. So first of all, the water physiological change that happens in a lithotic position. Lithotic position, since the legs are up, that's an increased venous return, which causes the transient increase in cardiac output, cerebral venous and intracranial pressure. Afterwards, the patient, these changes are only transient. The pressure will come back to normal. There can also be a reduced lung compliance. Patients who are obese or patients with large abdominal mass is present, the venous return can be very much might decrease because of the increased compression. It can lead to hypertrophic syndrome or supine hypotension syndrome. So we should be careful in these patients. And also, the lordotic curvature of the lumbar spine is lost. It can aggravate previous lower back pain. Coming to standard lithotomy, so the patient who lies supine with one or both arms extended laterally to less than 90 degrees in arm boards. So each of the lower extremity is flexed at the hip and the knee. Both ends should be simultaneously elevated and separated, so the perineum becomes accessible for the surgeon. So both ends should be simultaneously elevated because if they are lifted individually, it can cause torsion stress on the spine and can lead to injuries. Legs are also adequately padded to prevent compression injuries. As you see in this picture, the legs are held up using straps at the lower of the foot. This is the ideal position. And after the surgery, and the legs are to be lowered to the vertical supine position, they should again be brought together at the same time and lowered slowly. Again, to prevent torsion stress on the lumbar spine, they should be brought together, not individually. And since they walk slowly, it also permits gradual accommodation to the increase in cerebral capacitance, thereby suddenly avoiding sudden hypotension. Coming to high lithotomy, it provides an improved access to the perineum. This patient's feet suspended from very high pose. They're almost legs are almost fully extended on the thighs. The thighs are flexed 90 degrees or more on the tongue. This posture produces significant uphill gradient for arterial perfusion into the feet. Requires careful awareness of systemic hypotension to ensure that there's proper perfusion to the feet. Low lithotomy is for use in most urological procedures and procedures that require simultaneous access to the abdomen and the perineum. The degree of thigh elevation is only 30 to 45 degrees. So this reduces perfusion gradients to and from the lower extremities. It improves access to perineal surgery for members who may need to stand at the lateral aspect of the island. Coming to exaggerated lithotomy, here it's required in transferring access to the retropubic areas. That's why the exaggerated lithotomy position is right. The patient's pelvis is flexed ventrally on the spine. The thighs are forcibly flexed in the front, so the lower legs are aimed skyward. Here, shoulder support may be needed in order to stabilize the torso. If at all it should be used, it should be placed over the acromioclavicular area to minimize compression of the brachial plexus and adjacent muscles. The complications that are seen in this lithotomy position is one is nerve injuries, especially at the knee, saphenous nerve, common femoral and operator nerve can occur. So to avoid these nerve injuries, there should be proper padding at the knee, or what we can do is we can suspend the legs at the foot using a candy cane poles. This avoids pressure on the knee and provides pressure on the nerves. Also, there's a thing called leg compartment syndrome. can occur due to excessive staph pressure. This occurs in patients who are lithotomy for a prolonged period of time, more than 2 to 3 hours. So what happens is the perfusion reduces to the legs, which develops ischemia, and compartment syndrome can occur. So in surgeries that are prolonged more than 2 to 3 hours, occasionally lowering the legs for some time can, for a brief period of time, can actually help avoid this compartment syndrome. And coming to the picture on the right, the position of the arms are also important. When the arms are adducted, it is important that the fingers don't extend beyond the angle of the bed, because once the bed is cracked, and when after the surgery, they usually brought back to the normal position, and that time the fingers can get crushed. So it's important that the fingers can extend beyond the edge of the table. Coming to the frog leg position, which is modification, it allows access to the perineum, the medial thigh, genital and rectum rectum. So here the patient is positioned supine, and then hips and the knees are flexed. Hips are externally rotated with the soles of the feet facing each other. Here, support of the patient's knees to minimize stress and post-op pain in the hips is required. Thank you so much for listening.
Thank you, Dr. Aswin, for a wonderful coverage of all in a very crisp way in different positions, especially the supine with all these modifications. So I request anybody who's having any doubts or clarification, they can put it in the chat box, and we will address the questions at the end of the whole session. Next, I would like to welcome Dr. Anjane, who's a second-year DM Neuroanesthesia resident, for her presentation on lateral position and its modifications. Over to you, Dr. Anjane.
Thank you, sir. Good evening, everyone. Thank you for giving me this opportunity. I hope I am audible.
Yes. Yeah.
My topic is on lateral position in anesthesia. So what are we worried about during positioning a patient during surgery? Our main concerns are on whether the raised ICP and venous congestion, which can lead to increased brain swelling and increased venous bleeding in the surgical site, especially in neurosurgery setup. So this raised ICP and venous congestion can occur secondary to increased intra-abdominal pressure, or kinking of the internal jugular vein, or positioning of the head below the level of heart, and insufficient abdominal bolstering, and hyperrotation and flexion of the neck. And also airway compromise can occur due to hyperrotation and kinking of the hyperrotation of neck and kinking of tube, and extreme flexions of neck. And other complications like pressure ulcers and stretching of nerves, which can cause multiple nerve injuries, corneal aberrations, and thromboembolic complications. All these complications occurs just because of position. All these are because of the position-related complications. So the indications for lateral position are mainly intracranial surgery, especially the surgery involving posterior fossa, and also thoracic surgeries involving thoracic spine surgeries and lung resection surgeries, and also access to retroperitoneal structures, especially renal surgeries, are also done in lateral position. Also, surgeries of hip joint and shoulder joint are also done in lateral position, and other non-surgical indication like lumbar puncture. The physiology of lateral position, mainly the respiratory changes that occur in lateral position are whenever the patient is awake, the perfusion will be more towards the dependent part of the lung. This is because of the gravity. But the ventilation, it is also more towards the dependent lung when the patient is awake. It is because in the dependent lung, the alveoli are smaller, so which can be stretched more. So it is more compliant in the dependent part when patient is awake. And also the cephalad movement of diaphragm by the abdominal context, this will increase the effectiveness of diaphragmatic contraction. All these lead to net preferential ventilation perfusion more towards the dependent lung. Hence, in this compliance curve, where x-axis is pressure and y-axis is volume, this is a compliance curve. The dependent lung occupy the more steeper portion in the compliance curve, and the non-dependent lung occupy the less steeper portion in the compliance curve when the patient is awake and in lateral position. So once the patient is anesthetized, the perfusion will still remains the same because due to gravity, the dependent part of the lung will be perfused more. But in anesthetized patient, there is a change in ventilation. Here, the non-dependent lung will be comparatively more ventilated. This is because after anesthesia and muscle relaxation, the tone of the diaphragm and inspiratory muscles are lost, and also there will be a mediastinal compression towards the dependent lung. So all these lead to a shift of the dependent lungs position in the compliance curve to a less steeper portion. And also the non-dependent lung forms a more steeper portion in the compliance curve. So altogether, it will lead to a better ventilation in the non-dependent lung compared to the dependent one. Other physiological changes are in the cardiovascular system, compared to supine position, there will be a decrease in venous return and stroke volume and cardiac output, and a decrease in mean arterial pressure in lateral position, and also increase in systemic vascular resistance. In central nervous system, there can be a decrease in jugular venous resistance compared to supine position. That means a better jugular venous flow will be there. But with the neck flexion or neck rotation, there can be an increased jugular venous resistance. This is a study, observational study conducted in 2002 by Manikandan sir and Uma Maheshwar sir, which shows the effect of surgical position on pulmonary gas exchange in neurosurgical patient. In the study, they found that the oxygenation and CO2 elimination compared to supine position, oxygenation is compared to supine position is better with prone more than lateral position, and the CO2 elimination is better in prone position, and there is no effective change in CO2 elimination in lateral position compared to supine position, in which where there is a decrease in CO2 elimination. How to position a patient to a lateral in a lateral decubitus position. So team preparedness and teamwork is of utmost importance whenever we position a patient. The team usually includes surgeons, anesthesiologists, staff nurse, and technicians. So after standard anesthesia preparation, after endotracheal intubation, patients IV access it is preferred to take in non-dependent arm, and also arterial access it is preferred to take in a non-dependent hand to avoid false reading. And after adequate eye padding should be ensured, and sequential compression devices like pneumatic compression devices, as shown in the second picture, can be applied for a long duration surgeries to avoid DVTs. And a bite block is preferably applied to inserted to the mouth to avoid tongue injuries. And bladder catheterization, if required, can be done for long surgeries. And also, we should ensure that the catheter is adequately, as you see in the first picture, it should be adequately pasted over the thigh, and to avoid compression, catheter compression, which can again increase the intra-bladder pressure and intra-abdominal pressure. So the main pressure points that we are concerned during lateral decubitus position are shown in this picture. So we should we should give more importance to all these bony prominences. It should be adequately padded, especially the lateral, the dependent face, ear, the shoulder, the dependent arms, and the hip, especially greater trochanter, legs, the dependent knee, and ankles and feet. So how to position a patient to lateral decubitus? So after the general anesthesia preparedness, we should tie the center. If we have secured a central line, we should tie it appropriately to avoid accidental removal of central line. And also ET tube can be, if required, can be disconnected to avoid accidental extubation for a short time. And patient should be turned. Patient should be turned as a torso. Or patient, if having unstable spine, can be log rolled over using a log roll. And from head to toe, once you see, the head can be either kept in a headrest, or a Mayfield pins can be applied according to surgeon's preference. So once you in head, what we must ensure is the adequate neutral position of the head. It will prevent the cervical cord injury and cervical cord ischemia, which can lead to quadriparesis or quadriplegia. And also we should avoid excessive lateral rotation of the neck, which can compromise the venous drainage from the brain. And hyperflexion of the neck should also be avoided, because hyperflexion, it can cause decreased blood flow through the vertebral arteries, because already vertebral arteries passing through transverse foramina. So there can be decreased blood flow in vertebral artery. And also a patient who is already having a carotid artery stenosis or a carotid artery atherosclerosis, a minor hyperflexion can lead to secondary cerebral ischemia postoperatively. So 2-finger breath space should be allowed between the mandible and clavicle to reduce these complications. After head, we should look over the eyes and ears, especially the dependent eye and ears, which is more prone for pressure injury. So adequate, which can lead to corneal abrasion or pressure ulcers over the dependent ear. So adequate padding should be ensured. Coming to shoulder and arms, the dependent shoulder can be kept either in a bean bag that is shown in the first picture, or it can be fixed over a peg board. And it should be ensured that the arm should not be abducted more than 90 degrees to avoid brachial plexus injury. And in the axilla contains the neurovascular structures. So axilla should be kept clear, and the axillary roll should be kept below the axilla, and it should not be kept over the axilla. Axilla should be clear. And after positioning, we should ensure we should check for the pulses, peripheral pulses, to ensure that it is not vascular compromise is not there. Coming to legs. Coming to legs, the dependent leg is usually flexed, which gives more stability and also also minimize the stretch of the lower extremity nerves. And between the upper dependent and non-dependent legs, pillow is kept between these two legs to avoid compression of the bony prominence. Especially the lateral head of fibula contains common peroneal nerve, which is a superficial nerve, which once get compressed can lead to foot drop. And also we should avoid hyperflexion or hyperextension of the knee during positioning, because sciatic nerve passes through the hip and also knee, which can lead to sciatic nerve injury. And also gel pad should be kept at the ankle joint and feet at the pressure points. Coming to chest and abdomen, the mid and upper torso, it should be well secured with a Velcro strap or tape as shown in the picture. Between the fixation device and the patient, adequate foam padding or cotton should be kept, because this Velcro and tapes can cause stretch abrasions over the skin. So ideally a 3-point fixation is recommended, but if a fourth strap which is tied over the leg, as you see in the first picture, if it is there, it will allow maximal rotation of the patient during surgery without a fear of patient falling from the table. The modification of lateral position are mainly park bench position. Park bench position, it is mainly done for access to posterior fossa, especially for CP angle tumors. Here the trunk is rotated 50 degree lateral from 15 degree. It is rotated from the lateral position, and head is flexed at the neck and rotated such a way that the nose is facing the floor. This gives better access to the CP angle tumors. And flexed lateral decubitus position, or it is also known as kidney position. Here, it is usually done for retroperitoneal structure surgeries, renal surgeries. Here, there is a flexion. The point of flexion is seen at the level of iliac crust. So here, we should ensure that the point of flexion should not be at the level of flank or ribs, which can compromise the, which can lead to IVC compression. That should be ensured. Other modification is 3/4 prone. It is between lateral and prone position. This is usually in this, actually the patient's contralateral arm, it is placed along the body, and patient's contralateral hemithorax is little elevated from the body using a roll, and also the ipsilateral hand is positioned below the body, behind the patient's body. So this position is usually used for access to pineal region. The complications that we face during lateral position are peripheral neuropathy and pressure ulcers. These are the main two complications, and rarely postoperative visual loss and acute postoperative sialadenitis can occur. Peripheral neuropathies in this brachial plexus injury is more common, and following that ulnar nerve injury at the level of medial epicondyle, and also common peroneal nerve injury at the level of fibular head. So IAC recommendation tells that to avoid the brachial plexus injury, we should avoid excessive lateral rotation of the head, and also we should limit the abduction of arm less than 90 degree, and axillary roll should be kept, and we should clear the axillary space. And also whenever we are using whenever we want to put a central line, better go for a ultrasound technique to avoid injuries to the plexus. And also after that ulnar nerve injury, it passes through the medial epicondyle, which is a superficial nerve. So we should avoid excessive pressure over the posterior condyle groove of the humerus. And after that, pressure ulcers following peripheral neuropathy. It is usually seen in long duration surgeries, especially during surgery duration more than 12 hours. And also patient who is obese are more prone for pressure ulcers. Most common sites are greater trochanter of femur, iliac crest, axilla, lateral chest, which are the dependent region. And prolonged tissue pressure associated with intraoperative hypertension can also lead to severe muscle necrosis and rhabdomyolysis, which can lead to linear failure. Another complication is ophthalmic complication, which is rare in lateral position. This can occur due to increased intraocular pressure of the dependent eye. So excessive lateral rotation is thought to be the main cause for this increased intraabdominal pressure in the lower eye, which can lead to anterior-ischemic optic neuropathy or glaucoma or retinal artery occlusion. Post-op ciliadenitis is also a rare complication. It is also known as anesthesia mumps or acute postoperative ciliadenitis. So it occurs usually in the dependent parotid gland due to obstruction of the parotid duct. It can be, it is usually unilateral, but it can be bilateral also. It is usually painless, and it usually resolves in hours to days. This is a video showing how to position a patient in lateral position. So here you can see the patient is shifted to lateral position, whole torso, and the center lines are well secured, and patient is taken to the edge of the table, and adequate cotton padding is given below the shoulder and scapula. And ET tube, if required, can be disconnected from the patient, and also it is ensured that the circuits is not entangled between the patient's body and the paddings. And patient is after adequately positioning the patient, cotton paddings are here you can see the patient is supported anteriorly and posteriorly with bolsters, and cottons are kept between the skin and the fixation apparatus. And also the non-dependent arm, especially at the bony prominence, the cottons are kept at the pressure points to avoid pressure injuries. After that, after positioning, a 30-degree head up is given. Now you can see 30-degree head up is given. This is to avoid. This is to improve the venous drainage and to reduce the ICP. After that, the shoulder is supported. Shoulder is supported and padded well, so that the better access to CP angle. This is for the CP angle tumor. A better access to CP angle is ensured. And after that, patient is tied with a Velcro to prevent falling from the table. And here you can see gel pads are kept below the ankle joint. And also after positioning, the peak airway pressures are checked to ensure that the airway pressures are not high. Thank you.
Thank you, Anjane. It was very interesting and very elaborate on how to do positioning, various complications related to lateral position. From lateral position, now we move on to prone position and its modification. For that, I would request Dr. Sreeja, who is a first year DM Neuroanaesthesia resident, to come forward for her presentation. Over to you, Dr. Sreeja.
Thank you, sir. A warm good evening to one and all. First of all, I would like to express my deepest gratitude to the organizers of ICA, Sir, Madam, Sunny sir, and other senior members, and Manikandan sir for giving me this opportunity. So my topic for today is prone position. I hope I am audible, sir.
Ma'am, your voice is breaking, ma'am.
Am I audible now?
Yes, ma'am.
So we will be discussing the indications of prone position, the physiological changes associated with prone position, especially the effect on the cardiorespiratory system, and identify we will be discussing the various types of equipments used in prone positioning and the modifications of prone position like the comfort position, the niches position, and we will be discussing how to plan an extubation after a prolonged prone position and the complications associated with prone position, like how to manage an accidental extubation and how to do a CPR in prone position. So coming to the indications, the prone positioning is mainly done for the surgery on the posterior part of body. In neurosurgery, it is mainly for the posterior fossa procedures and the posterior spine surgeries, and PCNL and nephrostomies in neurology, the anorectal surgeries in general surgery, and the debridement of sacral ulcers or bed sores in plastic surgery, and the Achilles tendon repair in ortho. So coming to the physiology, first the effects on respiratory system. It is well established that prone position improves the lung oxygenation. Let's see how this happens. So what happens to the lung volume is that when a patient becomes supine from upright position, there is a drastic fall in functional residual capacity. There is almost 44% decrease in FRC. But when the patient becomes prone, the fall in FRC is much less when compared with the supine position. It is less than 12%. And pulmonary blood flow, it is more concentrated to the dorsal part of the lungs in supine position. And when the patient becomes prone, the blood flow is more uniformly distributed from the posterior part to the anterior part. So there is more uniform distribution of the pulmonary blood flow. And what happens to the ventilation is that in supine position and in prone position as well, the ventilation is more concentrated to the dorsal as well as the mid portion of the lungs, and this is due to the properties of the bronchoalveolar architecture. So the overall V/Q mismatch, what we see in the upright and supine position, is reduced in prone position. Coming to the cardiovascular system, recent studies with the esophageal echo has shown a 10 to 20% reduction in cardiac index in healthy anesthetized patients in prone position. And this is mainly due to the decrease in preload due to IVC compression or a reduced left ventricular compliance due to increased intrathoracic pressure. Usually, in a healthy adult, this is well compensated by increase in cardiac contractility and LV ejection fraction. Various studies have shown that the negative effects of prone positioning is more severe in patients with poor baseline cardiac function. So before you make a patient prone, make sure that the patient is euvolemic, especially in preload dependent patients. Now we will see the equipments used for prone positioning. This is the Wilson frame, which has got a laterally adjustable gel pads to reduce the chest compression. And this Wilson frame helps to improve the surgical access to the lumbar spine The problem with Wilson's frame is that this frame itself is a risk factor for causing post-stroke vision loss because when we position, the head position is below the level of the body. And this is the Montreal mattress. The central cavity shown here helps to reduce the abdominal compression. But this can cause abdominal compression in obese patients. And this is the Jackson's table, which can be rotated 180 degree. And this is the Ball's test. What we use in our setup is the Ball's test. This is easily available, and the advantage is that this can be adjusted according to the size of the Ball's test can be modified according to the body habitus of the patient. And for this is how the patient is positioned in Wilson's frame. This is how in Jackson's frame, and this is how the patient is positioned on Ball's test. Now coming to the head positioning aids, either we can use a headrest or we can clamp the head in pins. So these various forms of headrest are available. This is the form of gel headrest. This is a protective helmet with a mirror system to check on the eyes, lips and nose. And this is the horseshoe headrest. These headrests are usually used for head in neutral position. The disadvantage of this headrest is that if it is of improper size, this can cause, or a poor positioning can cause excessive pressure necrosis of the chin, forehead, or eyes. Coming to the pin system, these are the two pins commonly used. One is the Mayfield head holder. Sorry for the interruption. One is the Mayfield head holder, which has got 3-pin system. 3 pins it has got, and this is the Sugita head frame, which has got 4 pins. So advantage of pin system is that there is no pressure on the face, and the head, the surgeon can adjust the head according to the neck flexion and extension. So we should make sure that the neck is not too much extended or flexed, and also the application of pins can cause hypertension and tachycardia. So we should ensure adequate depth of anesthesia before the pin application, and also we should provide additional analgesia at that time. And whether this clamps or the horseshoe headrests, they are both attached to the table with the help of articulating supports to the operation table. So make sure that they are connected tightly so that the head won't fall down, and also make sure that while the patient is positioned in pins, the body should not move, because the movement of body can cause scalp laceration as well as injury to the cervical spine. So always be careful regarding that. And how we are going to manage a patient who is supposed to undergo a surgery in prone position. So whenever we see a patient in the pre-operative clinic, we should determine the patient's suitability for prone position. That is, to how extent the patient can tolerate the position, and make sure that all our equipments are of standard and are ready for use. Always anticipate and be ready to manage any adverse hemodynamic or ventilatory changes. Also, follow a checklist, which I will be discussing what we follow in our institution for prone positioning. So in pre-op assessment, identify the patient at risk. So check his neck mobility, other joint mobilities, and patient who will be positioned with their arms overhead with the abducted like this, what is shown in the right. They should be able to demonstrate this position comfortably in the pre-op period. So if they cannot do that, we can consider them position like this, like the arms by the side of the body. And finally, rule out the presence of any breast implants, pacemakers, or ostomy bags, because this may require additional padding and support during care during the prone positioning. So a word regarding airway management. The most common strategy for airway management is that we induce and intubate in the shifting trolley itself and then make the patient prone. So it was proposed that if we make an awake patient prone and then induce and insert a supraglottic airway, this can reduce the airway injuries and other pressure injuries. So various studies have been done regarding this, and they found no statistically significant difference between the these two techniques. What they found was there was only a statistically significant difference between the start induction and the time from the induction to the start of surgery. So they don't advise us to use this as a regular method, but we can consider this in case of some unstable spine when the positioning itself can worsen the neurological deficits, and we can assess we can assess the neurological deficit immediately after the positioning. And hemodynamic management, meticulous positioning to reduce the thoracic and abdominal pressure is the key to maintain hemodynamic stability. So for long procedures, we here use invasive arterial BP monitoring whenever indicated. And if the patient has any cardiac disease, we use non-invasive cardiac output monitoring like a cheetah monitor, and we monitor the cardiac index and we manage the fluid according to the stroke volume variation. Inotropic agents may be indicated in some patient, and the stretcher on which the patient is induced should remain inside the operation theater until the patient is stabilized, his vitals are stable in the prone position. So how we do it, the checklist for positioning. So we have seen the patient, make sure that the equipments for prone positioning are ready in the operation theater. Ensure that the equipment is appropriate for patient's age, weight, and body habitus. And we should have at least 5 persons skilled lifters for making the patient prone, 1 at the head end, 2 at the shoulder girdle, and 2 at the pelvic girdle. So once everybody is ready with their position, usually the anesthetist is the one who manages who coordinates the positioning, except in cases where the patient is clamped on pins and turned, where the surgeon holds the head in clamps. So after everybody is ready, we secure all the lines to prevent the dislodgement and increase the FiO2 to 100%. And then we usually keep the pulse oximeter and the arterial BP. We disconnect the other monitors and disconnect the breathing circuit, and the anesthetist counts down for the turn 1, 2, 3 and shift. We turn the patient to prone, maintaining the head and neck in alignment during the turn. And after positioning, we run an ABCDE checklist, that is airway, breathing, circulation, disability, and exposure. In airway, we immediately reconnect the airway breathing circuit. We restore the mechanical ventilation, and never forget to recommence the anesthesia. Otherwise, the patient will have awareness. We ensure that there is no kinking of ET2, and we secure the breathing circuit. And we check SCO2, ETCO2. We check the peak airway pressures and auscultate both lungs to rule out any endobronchial intubation. And we reconnect NABP, 0 arterial line, and we check the rhythm and reconnect in IV lines and check the patency. And in head to toe screening, we first check the eyes. The eyes are properly taped and there is no pressure on eyes, ears, and nose. And we check that tongue is inside the mouth and not protruding between the teeth. If needed, we can use a bite block before insert a bite block before proning, but it is better to use a soft gauze rather than a hard bite block, because hard bite block can cause injury to the palates. And always maintain a 1 to 2 finger breadth between the chin and the chest to avoid excessive neck flexion as shown in this photo. And all the body prominence should be padded, and shoulders and elbows, make sure that they are not abducted beyond 90 degrees, and the chest fold is well padded. If on board stays, we immediately displace the breast, and the abdomen should be free, and also the genitalia should be free. We also apply a warming blanket and DVT pump to the patient, and we document every action taken, and we check the eyes and nose every 30 to 40 minutes. And we place a board that do not remove the structure. The patient is prone and the structure is set just outside the theater in case if some catastrophic occurs. So this is a video showing the bolsters are made ready. The patient's head is clamped in pins. extra padding is done on the bolsters, and when the anesthetist counts down, the patient is made prone. So coming to the variations of prone position, first is the Concorde position. Concorde is actually the name of a supersonic airliner. See how the tip looks. Like that, the neck is positioned and neck is flexed. Reverse trundle is given and arms are tucked alongside to the trunk and the legs are elevated. This is the best position for lateral suboccipital approach for the posterior fossa tumors. This is how the neck is flexed and the patient is positioned. And this is the neatest position. This is for improving the access to the lower spine and also for the management of vesicovaginal fistula. 3/4 pound, which is already discussed by Dr. Anjane, and how to plan an extubation after a prolonged prone position. So, if some of the risk factors or red flags are present, like if the surgery was prolonged more than 8 to 10 hours, if there was a large volume of blood loss and massive transfusion of fluid shift, if the patient has significant cardiopulmonary comorbidities or morbidly obese, if it at the beginning it was a difficult or a traumatic intubation, and we check, and also we check for the facial, tongue or airway edema. If there is severe edema, we can wait for extubation, and we can consider to give head up for the patient and can give start on steroids. And before extubation, make sure that the patient is fully reversed from neuromuscular blockade and make sure that the patient is hemodynamically stable. Also make sure that you have skilled staff to assist you while extubating, and all the equipments, the difficult airway cart, the tracheal tube exchanger, everything is ready for immediate access. So, and you can check the airway patency by doing a leak test. So how this leak test is done? So you put in assist volume control mode and see the difference between the inspired and the expired tidal volume. So you see for at least 6 breaths, because the expired tidal volume comes to plateau only after a few breaths. If the difference is more than 100 to 110 ml, there is a reasonable patency of the airway, and so you can move forward with the extubation. So whenever you have a doubt, so if I extubate, whether I will be able to re-intubate, whether I will be able to mask ventilate, always extubate with an airway exchange catheter or a tracheal tube exchanger in place, because these two exchangers are usually well tolerated and you can easily re-intubate the patient. Now coming to the complications. So what all complications can happen during the time we change the position? There can be dislodgement of endotracheal tube and other arterial or intravenous lines. Oxygen desaturation can happen because we are disconnecting the breathing circuit. So to prevent that, make 100% ventilate with 100% oxygen just before disconnecting. And we are also disconnecting anesthesia, so patient awareness can happen, and also physical injuries to the patient and staff, and peripheral pressure injuries like peripheral nerve injuries, pressure necrosis of the skin. Some patients can even develop allergy to the headdress, so contact dermatitis can occur. And abdominal compartment syndrome due to excessive abdominal pressure and visceral ischemia like hepatic ischemia, pancreatitis have been, there are case reports regarding that. And lymph compartment syndrome can also occur. Venous air embolism is another complication which will be more discussed in more detail in sitting position. And post-operative visual loss. This is a rare but serious complication. So the major causes are compression to the eye and can result in ischemic optic neuropathy or a central retinal artery occlusion. So what is common in our setting is in spine surgeries is the posterior ischemic optic neuropathy. So ischemic optic neuropathy mainly classified into non-arthritic and arthritic, of which non-arthritic mainly happens during the perioperative period. So male gender, obesity, Wilson's frame positioning, as I told earlier, prolonged duration of surgery, large blood loss, all are risk factors for post-operative visual loss. So whenever a patient complains of sudden painless loss of vision or inability to perceive light or motion, loss of visual fields or decreased visual acuity in the postoperative period, immediately do an ophthalmology consultation and a neurology consultation. So airway complication, there can be kinking of the ET2, obstruction due to secretion, or endobronchial intubation. This is the picture showing how severe the airway edema can happen. So if the face, eyes and lips are edematous like this, this is a red flag sign that you don't extubate the patient immediately. You wait for the edema to set in. Now, how to manage an accidental extubation in prone position. This is a dire emergency because there is less time to re-establish the airway, because we will be usually ventilating with 50% FiO2 and patient can desaturate suddenly. And as anesthetists, we are not much accustomed to perform back mass ventilation or other airway maneuvers in prone position. And we have limited access to the airway due to the clamps and headrest. So if something like a extubation happens, if it is a partial extubation, you can deflate the cuff pilot balloon and re-advance the endotracheal tube and confirm with EtCO2 and auscultation. And if the patient is stable, you can proceed with the surgery. But if it is a total extubation, you immediately call for help, call for stricture, call for difficult airway cut, inform surgeon immediately to stop the surgery, remove the surgical instruments and pack the wounds. And if the head is in clamp, ask the surgeon to immediately declamp and try to make the patient immediately supine. If able to make supine, you manage the airway in supine position, or else you try to insert a supraglottic airway, whichever you are familiar with, you can use. And insert an LMA, and if the patient is stable, you can proceed with LMA, or if you are confident enough, you can even try an intubation via the supraglottic device. And coming to the last portion, this is the resuscitation in prone position, also known as reverse CPR. The main aim for starting a CPR in prone position is to reduce the no flow time. So American Heart Association recommends that CPR in the prone position is reasonable when the patient cannot be replaced in the supine position immediately, particularly in hospitalized patients with an advanced airway in place. So we can start CPR in the prone position itself. This is the area where we should give the compression, chest compressions, that is between the two scapula over the T7 to T10 levels. The Intensive Care Society also recommends that two-handed technique for chest compression, and also the use of a counter pressure from the other side at the lower end of the sternum can be given by other person if possible. And this is the position for defibrillator pads. Either it can be placed anteroposteriorly or by axillary position, or at the left mid-axillary line, and second one over the right or even the left scapula can be placed. So in short, we should properly assess the patient and prepare the patient, make sure that all the equipments are updated and undergo regular safety checks, and make sure that we have skilled lifters, and we should follow the checklist as I discussed, and we should also document everything we have done. Thank you all for your patient listening.
Thank you, Dr. Sreeja. Very nice, wonderful topic. I have listened about the prone position. Now, time for more important position, which is more fearsome for anesthesiologists, that is the sitting position. To talk about sitting position, I would like to welcome Dr. Arvin Ahuja, who is the final year president of DM Neuroanesthesia at SCTIMST. Over to you, Dr. Arvin.
Thank you, sir. Good evening to everyone. So are my slides visible? Good evening, everyone. I'm myself, Dr. Arvin, DM final year resident over here. And I bring warm greetings from my institute, Sree Trivandrum Institute of Medical Science and Technology. My job for today is discussing the nuances of the sitting position. Although it's seldom used, but it is the most feared position for the anesthetist because the complications, once they happen in sitting position, they can be really life-threatening. I'll be discussing my today's talk under following broad subheadings. To give a brief synopsis, I'll be discussing the general overviews and principles, the safety checklist. As has already been discussed, I'll be reviewing the safety checklist once again. Then the goals, then indications, advantages, and disadvantages of the sitting position. I'll be discussing the salient points which we should consider when we are going for PAC evaluation of a patient being considered for sitting position. What are the physiological changes that occur in sitting position? Then how to conduct the procedure per se. After that, what are the probable complications which can happen in sitting position and how do we manage them? And lastly, I'll be inviting the question and answers. Coming to general principles, as has been discussed in previous discussions, it is the position of the patient should be well planned and it should be envisioned during the PAC evaluation. We should know what all things are required in the OT, how should we prepare our OT, and what all things to keep ready. Then it is a joint responsibility, the shared responsibility for the entire team. It's not just responsibility of the anesthetist. Surgeons, the nursing staff, and the ancillary staff are equally responsible for the positioning of the patient. And it's a all hands on deck principle. So the common requisites, the common prerequisites that we should ensure when we are doing position for any patient. As an anesthetist, it is our imperative to establish a secure airway, to ensure that there is stable ventilation and oxygenation for the patient, to ensure that there is an adequate depth of anesthesia, to ensure hemodynamically stable, the patient is hemodynamically stable. And if we should try to preserve maximum number of monitors that are possible. However, if we are disconnecting some monitors, for example, ECG, we need to disconnect while positioning the patient prone or even for sitting position. So if we are disconnecting any monitors, we should try to minimize the phase of blackout. Then all our indwelling catheters, ET, Foley's, Riles tube, any neuromonitor probes, all those should be well secured to the patient. The general principle is that the body is positioned first, followed by the head. Then one should be extra vigilant during clamping and head positioning, more so because in sitting position, you should adequately cater to the stress response which happens during the pinning of the head. After that, once the position is secure, once the head is secured, you should ensure that there is no excessive torsion in the neck, and there are safe degrees of rotations which can be allowed. Example, when the surgeon wants to rotate the head laterally, the maximum degree of safe rotation that can be allowed is 45 degrees. Beyond that, if the surgeon wants extra rotation of the lateral rotation of the head, then a pillow should be placed below the ipsilateral shoulder. Next, after the position of the head and neck and the body, we should ensure that the surgeon has an optimal trajectory to the lesion. And this trajectory and this position, your final position of the patient, should give maximum gravity-assisted retraction and minimize the active retraction from the surgeon. And hence, this can help in minimizing the retraction injuries. Then there should be, we should also ensure that there is optimal venous drainage. There should be no extra tight knots around in the neck area, and there should be the drainage should be optimal. The pressure point should be well cushioned, and the body should be strapped to the table. After any positioning, as has been discussed previously, we execute a position safety checklist for all our patients here in our institute, and this includes A, B, C, D, E, F. A stands for airway. If the circuit was disconnected, you reestablish the airway. You reestablish the ventilation in the patient, ensure that your plateau pressures are fine and your peak pressures are fine. You reestablish the circulation. You reestablish all your disconnected monitors, ECG. You reconnect, and you see for hemodynamic stability in the patient. The patient should not have any hypotension post positioning. Then you go in for D stands for disability. That means you execute a head-to-toe checklist, as has been discussed previously by Dr. Sreeja. Then exposure means that, especially it's more important in sitting position, your face area should be well exposed. If you are anticipating an awake, if the patient is undergoing an awake craniotomy, your airway should be always accessible. And then all your limbs should be visible and accessible. Then F stands for follow-up. That is, you should keep checking your pressure points every 30 minutes to 1 hour. Coming to goals of any safe positioning, The goals mainly are to provide a physically and physiologically safe patient and have an unhindered access, especially when the patient is undergoing awake craniotomy in a sitting position, to anticipate and prepare for complications. And in this, I mean, we should be able to diagnose the complications early, and we should know how to treat them well in time. Then last aim is to facilitate the surgery and the ergonomics of the procedure. This, the last aim should not be at the cost of the above three aims. Now coming to the indications, what all are the indications for sitting position? Sitting position is mainly indicated for midline pathologies. As here we can see, for vermin pathology, cerebellar vermis, if the lesion is involving the cerebellar vermis, or if the lesion is involving the fourth ventricle, or if there is a pineal pathology, for that also sitting position can be used. For CP angle tumors, it's rarely used, but CP angle tumors can also be done in sitting position. Then we have lesions of the quadrigeminal plate, that is a tectal plate. For that also sitting positions can be used. Then for cervical laminectomies and decompressions, the sitting position is also feasible. Coming to what are the advantages and disadvantages of sitting position, there are both surgical and anesthetic advantages. From the surgical side, it gives excellent surgical exposure. There's a almost dry bloodless field because the blood trickles down. And there is from the anesthetist viewpoint, there's a superior access to the airway. There's decreased spatial swelling, improved ventilation, and the face is visible if we are planning for cranial nerve monitoring. That is cranial nerve stimulation. If you are planning for EMG monitoring, for example, in CP angle tumors, the face is adequately visible, and that helps in neuromonitoring. Then what are the disadvantages of sitting position? The main dreaded complication of sitting position is venous air embolism. And if it is only limited to the venous side, it can still be managed. However, if there occurs a paradoxical air embolism, which happens if the patient is having a patent foramen ovale, then that can lead to severe complications, like patient can have a sudden MI, patient can have a stroke. So these are some of the most dreaded complications of the sitting position. Apart from that, the hemodynamic perturbations are maximum for sitting position. Then because the head is elevated above the heart level, there is a decrease in the cerebral perfusion pressure and simultaneously decrease in cerebral oxygenation if proper CPP and MAP is not maintained for the patient. Another complication which can happen in the per-op setting is pneumocephalus. This happens because of the inverted soda bottle mechanism. I'll be discussing this in detail in the coming slides. Another complication is macroglossia, which can happen. Then there can be cord ischemia. If we have, if the anesthetists and the surgeons have been negligent and the patient is in a very hyperflex state, then that can lead to cord ischemia. Then SDH is another complication which can occur. Now coming to the contraindications for sitting position, there's a certain absolute and certain relative contraindication. Absolute contraindication, as I already discussed, the patient is having a patent foramen ovale, then that becomes an absolute contraindication. Why? Because if there is a venous air embolism, that can go to the arterial site and cause MI, and that can cause stroke. So that's why it can cause paradoxical air embolism, and hence PFO becomes the absolute contraindication for sitting position. Then if the patient is having features of cerebral ischemia when patient is upright and awake, that becomes a contraindication. For example, if patients are having vertebrobasilar insufficiencies, you always need to screen these patients for vertebrobasilar insufficiencies, especially if the patient is having a history of syncopal attacks, history of dizziness, giddiness, and dysphagia, the 5Ds of typical for vertebrobasilar insufficiency. You need to screen the patients for all these things, and these becomes an absolute contraindication for sitting position. Then if there is a ventricular atrial shunt which is in situ already in a patient and which is patent and draining, so this becomes an absolute contraindication. Again, because there's a probability of pneumocephalus that develops, and pneumoventricle also can develop, and that can then further cause a venous air embolism. Then if there is a ASD with with a shunt reversal with right atrial pressures more than left atrial pressures, so this again becomes a contraindication, absolute contraindication for sitting position. Now coming to relative contraindications, these are extremes of age, uncontrolled hypertension, COPD, degenerative disease of the spine, cervical spondyloarthropathies, and myelopathies. Cervical spondyloarthropathies and myelopathies I'll be discussing in the subsequent slides. There is a special point in the cervical spine, that is C5, against which the maximum compression of the cord can occur. So if the patient is already having features of cervical spondyloarthropathy, so this can exaggerate and it can cause cord ischemia. So this becomes a relative contraindication for sitting position. Now, coming to salient points which we should look for in a patient while going for a PAC evaluation, if the patient is planned for a sitting position. Is the patient planned for awake, or is the patient planned for under GA? If the patient is undergoing awake craniotomy in a sitting or a semi-sitting position, you should be thorough with the airway of the patient. A difficult airway is a relative contraindication for a sitting craniotomy. And if the patient is having any features of difficult ventilation, for example, morbid obesity or obstructive sleep apnea, and then you're giving a sleep phase of the awake craniotomy, and that time you can have a threatened airway and you can lose the airways, more so if the patient is having a history of OSA. Then you have to thoroughly look for cardiac evaluation in your patient if you're planning to have a sitting position in the OT. Why? Because there are, as we have discussed, there are extreme hemodynamic perturbations which can occur, and hence these patients who are going for sitting position, they are prone for hypotension. And hence, if the patient is already having an underlying cardiac disease, a coronary artery disease, he will have poor tolerance for hypotension. So hence, a severe coronary artery disease, untreated coronary artery disease becomes a contraindication again for sitting craniotomy. Then you have to do a contrast 2D echo. A plain 2D echo won't suffice. You have to do a contrast 2D echo to rule out a pulmonary, a patent foramen ovale. Why is this required? As we have discussed, venous air embolism, if it occurs, the air bubbles can travel through a patent foramen ovale and come onto the arterial side, and over there they can cause severe complications. Then what are the contrast mediums that you can use for a contrast 2D echo? You can use EcoVis media. It is a galactose L isomer, which can be used as a contrast. And you can use agitated saline bubble study. And simultaneously, when you're giving the contrast, if you tell the patient to do Valsalva maneuver, that can increase the sensitivity of your contrast 2D echo for diagnosis of a patent foramen ovale. Then, as we discussed, we should always screen the patients for vertebrobasilar insufficiencies, for cervical canal stenosis, for cervical spondyloarthropathies, myelopathies, or are there any cervical osteophytes in the patient? You need to rule all these out if you're taking a patient for sitting position. Next, if the patient is having any history of platypnea or orthodeoxia, or if there is any right to left shunt in the patient, which is hemodynamically significant, this you need to be careful during a PAC evaluation. There's something called as white cord syndrome. You should be wary of this. Now, what is this? You might have evaluated your patient well during the pre-op period. During the operative period also, the patient, it might have been a totally uneventful course. But suddenly in the post-operative period, patient develops a deficit, a hemiparesis on one side of the body. And the surgeons will be quite early to blame for the position-related complications. But what is white cord syndrome is, it is, in spite of all precautions, it's a reperfusion injury which happens in the spine. It happens when there is a long-standing compression of the cord. Suddenly, when the compression of the cord gets released from the decompression, for example, with the laminectomy, there is an increased perfusion of the spine which happens, which causes free radical and increased reperfusion injury results. And this can cause transient hemiparesis in the patient. The differentiating feature is that this is a transient phenomena, and usually it improves with the help of steroids. Now, coming to the physiological changes that occur in sitting position, first we'll be discussing the cardiovascular changes. Since there is pooling of blood in the lower limbs, there's a decrease in the venous return, because of which there's a decrease in the stroke volume, there's a decrease in the cardiac output, and also in the pulmonary capillary wedge pressures. And all these can manifest as profound hypotension. Then, as a reflex mechanism, there's increase in the heart rate, there's increase in the systemic vascular resistance, and also in the peripheral, and also in the pulmonary vascular resistance. Then coming to the respiratory changes, because the diaphragm is displaced downwards, there is improved ventilation, there is increase in the FRC and the TLC, there is less of atelectasis that develops, there is decrease in the VQ mismatch, and the shunt fraction also is decreased. So overall, the ventilation parameters are better with the sitting position. Coming to neurological consequences of sitting position, the physiological changes, there's a decrease in ICP. However, the neurological consequences depend upon totally on how you have positioned your head and neck. If there is increased torsion in the neck, if there is impediment to the venous drainage, then there's there can be also an increase in the ICP. And arterial blood pressure reduces by every 0.77 millimeters of mercury for every centimeter gradient increase above the heart level. Now, coming to the safe conduct of the procedure, the induction is completed as routine as in the supine position. All the prerequisites and the pre-position checklist is executed. then the hands can be secured across the body temporarily until the patient is put into sitting position. You can obtain your baseline neurophysiological monitoring, which is required in some patients. And your head and neck should always be supported whenever you are moving the patient. You can augment the venous return by placing a pillow below the thighs, and more so by placing the pneumatic compression devices. There are special anti-gravity G suits which can be used for sitting position. Then it's the positioning starts always with the head low first, followed by back up. You will first give a Trendelberg position, followed by breaking of the table and making the patient sit slowly. And all these maneuvers are slow, gentle, and graded incremental movements. And you can monitor the movements of the table with the help of a goniometer. Every movement should not be more than 15 to 20 degrees. It should be slow, graded movement. In between, you should give the time for the hemodynamics to adapt to the new position. And every time, the arterial transducer has to be repositioned at the level of the tragus. Now, this is how we position our patients. There has to be adequate gel pads to be placed everywhere, especially at the hip joint. You have to prevent injury to the sciatic nerve at the elbow joint and then behind the shoulders. There's a lot of paraphernalia which is involved in the OT when the patient is undergoing sitting position. You should have adequate space throughout around the patient to move about. This is how we conduct the sitting position in our setup. Then you have to be very sure how your vertical bar is placed of the handrest assembly of the head clamp assembly. The vertical bar should always be present, always be attached to the vertical part of the table, so that in case you need to flatten the patient, if there is an emergency, for example, a venous embolism occurs, you should be able to immediately flatten the patient, rather than if the bar is attached to the horizontal part, you will be facing difficulty in flattening your position. Then these are how we do awake craniotomies in sitting position. There has to be long drapes. A tent drape has to be placed across the patient's head. And this is on the left side. This is a Lexel frame. You should always be handy with the screw and the screwdriver of the Lexel frames in case if you need to unscrew the frame and establish a secure airway in case of emergency. Now coming to classical versus a modified sitting position. The classical sitting position, as you can see, the legs are flat and they are below the level of the heart. This is depicted in the left figure. In the right figure, you can see this is the modified version of the sitting position. And this, the legs are elevated to the level of the heart, so that this helps in augmenting the venous return to the upper body. And there is also a decreased incidence and severity of venous embolism noted in the modified sitting position. So when given a chance, however, a modified sitting position is not tolerated by an awake patient. Hence, it can be a patient can be positioned in modified sitting position only if it is the patient is under GA. Now coming to a few complications of sitting position, the most dreaded complication is the venous air embolism and the paradoxical air embolism. The severity of this depends upon the rate and the volume entrained. That is, how rapidly the air is being entrained and what is the volume of air that is being entrained. The pulmonary capacity to clear the entrapped air becomes overwhelmed after a certain time, and this causes an obstruction to the pulmonary circulation, and this increases your pulmonary artery pressures. The cardiac output is reduced because of a mechanical airlock which occurs in the right ventricular outflow tract, and this causes a mechanical overdistension of the right ventricle. Volumes more than 2 milliliters per kg can be lethal. The monitoring modalities are various, and we can use transesophageal echo, which has a sensitivity to detect 0.02 ml per kg of air, recorded Doppler 0.05, ATCO2 0.25, ATN2 0.5, ECG 1.25, and esophageal stethoscope can detect 1.5 ml per kg of air. The characteristic murmur which is detected is a Melville murmur. And in transesophageal echo, the best view that we can have for detecting venous air embolism is a mid-esophageal bicable view, or also a right ventricular inflow-outflow view to detect if there is any obstruction of the outflow tract. Now, this is a video
Arvin, I think you're muted. Can you unmute?
Then coming to pneumocephalus, pneumocephalus happens because there's a diminution of brain volume. Example, if you're using osmotherapy or if you're instituting hyperventilation or if there's sudden, because the CSF has passive drainage in sitting position. So that also aids in the development of pneumocephalus. It occurs because of an inverted soda bottle mechanism. That is when, for example, when you have invert a soda bottle, the air tends to go up in the bottle. So it's a similar mechanism. The air tends to get entrapped into the upper sphenic vault, and that leads to pneumocephalus. The presentation is confusion, headache, convulsions, neurological deficits in the immediate post-op period. And the Mount Fuji sign is a characteristic sign which is seen on the CT scan. The management includes giving 100% FiO2, monitoring for any drop in GCS, and anti-seizure medications. If it is a tension pneumocephalus, then immediate surgical intervention is required, and burr hole evacuation needs to be done. Coming to other complications which can happen, if there is extreme flexion of the neck, that can cause compression of the cord at this, particularly against the C5 vertebra. That is the reason for this is the space available for cord is minimum at the C5 level because the cord is thickest at around this level in the cervical region, and hence it has a tendency to get compressed across the C5 vertebra. And that can lead to decrease in the regional cord perfusion, and this can be aggravated by hypotension also. Your neurophysiological monitoring can help you detect this, and hence it's advisable to keep patients under SSCP and MEP monitoring when they are undergoing sitting position. The other common injuries that we have discussed are peroneal nerve injury, sciatic nerve injury, and recurrent laryngeal nerve injury, which can also occur. Then macroglossia and airway edema is another complication which can happen in sitting position. Thank you.
Thank you, Dr. Arvin. In between, we lost your voice. Anyway, it was a very nice presentation with the video of showing this air embolism. So that brings the end of the fine talk by our residents. I would like to ask my co-chair, Dr. Jeeva George, to summarize and then bring her thoughts. Dr. Jeeva.
Yes, sir. So, I will share my screen just to show what are the current guidelines that are there regarding this. Is my screen visible?
Yes.
So this has come in 2018. This was a perioperative peripheral nerve injury after general anesthesia. It was a systematic review, and this showed that brachial plexus injury was the most common, followed by ulnar nerve injuries, and also in the upper limb there was radial and medial nerve injury.
Ma'am. Ma'am, your screen is not visible, ma'am. Are you showing the screen?
Yes.
It was visible, ma'am, initially, but it stopped. The screen sharing stopped, ma'am.
Just a minute. Is it visible now?
No.
Yes, ma'am.
No.
Okay. So this was a systematic review that came out in 2018, which showed that the most common was brachial plexus injuries, and followed by ulnar nerve, and also there was sciatic nerve and femoral nerve injuries. And So this was the recommendations that was given by ASA based upon the closed scheme analysis. And for the prevention of these injuries, for ulnar injuries, it was shown that to avoid excessive pressure as well as to keep the arm in a proper position. And for brachial plexus injuries, the steep head down position, especially the Trendelenburg position, was most common. So what they said was not to abduct the arm more than 90 degrees, as well as to avoid the placement of a high axillary roll, especially in the decubitus position. And for lumbar and spinal cord injuries, they asked to be aware of the injury, that is because it was increasing because there was upcoming of regional anesthesia towards in late 2000s. And also sciatic and peripheral nerve, peroneal nerve injuries was there. And this was more common in lithotomy positions. So this also, they said that to use two assistants and to lift both legs simultaneously to prevent these injuries. So this was a practice advisory that was given for the prevention of peripheral nerve injuries. This included the preoperative assessment, that also included the body habitus of the patient, to see if there is any pre-existing neurological symptoms, then if the comorbidities like diabetes and peripheral vascular disease was there. And also we have to assess whether the patient can tolerate that procedure in that particular position. And for the upper extremity positioning, that was already said before, to avoid extreme abduction as well as to avoid using shoulder straps, and also in the lower limb to limit the hip flexion. And also in the lithotomy position, to elevate the legs in the straps and to prevent the peroneal nerve injuries. And also they also said to not use bands across the chest to avoid brachial plexus injuries, and also especially in the steep head down position. And also equally important was the post-operative assessment, to see whether the patient has developed any new onset deficits. And also it was as well as important to document especially what kind of position patient was in and what kind of preventive measures that was taken in the intraoperative period to avoid these injuries. And another not so common but very important was the post-operative visual loss. The main risk, this is mainly seen after cardiac surgeries as well as in spine surgeries, especially lumbosacral fusion surgeries. So there are like a few risk factors for this. The one is according to patient factors, like male patients are more predisposed, then use of a Wilson's frame, then obese patients, and prolonged duration of surgery in the prone position, that is more than 6 hours. And also when the amount of blood loss is high, and when resuscitation has been done with more of crystalloids than colloids. And so this will lead to leakage of the fluids, especially around the optic nerve, that can lead to direct axonal injury. And also when the cup to disc ratio was reduced. And also if the patient had hypotension during the intraoperative period. So this has lead to anemia and hypoxia. So all these factors reduces the perfusion pressure to the optic nerve. So that can lead to post-operative visual loss. So this he has already discussed, that is anterior ischemic optic neuropathy, posterior ischemic optic neuropathy. So anterior ischemic AION can be delayed presentation, that is after 24 to 48 hours, while PION can be immediate post-operative period. An important factor is that there might not be any external features of any injury, and only patient might be complaining of visual loss, painless visual loss. And then central retinal artery occlusion can be seen when there is a direct pressure that is applied over the eyes. And this also we can see externally, we can see any eyelid edema can be there, periorbital ecchymosis can be seen, their proptopsis can be seen. And cortical blindness also presents immediately after surgery, and this can be typically unilateral. And glaucoma also can be there in the post-operative period. It can cause intense pain and blurred vision. So this is a practice advisory that is being given for POV and spine surgery. It came out in 2019. So in the pre-op itself, we have to identify patients who are high risk, that is with comorbidities, hypertensive, diabetic patients, patients with peripheral occlusive disease, CAD, carotid artery stenosis, obesity, and when the surgery is of prolonged duration and massive fluid shift and blood loss is anticipated. So in this, if you're anticipating, we have to take an informed consent from the patient. regarding the increased risk of perioperative visual loss. And the blood pressure is the most important part of the management, because sometimes surgeons can ask for deliberate hypotension. So the decrease in blood pressure should not be more than 20% of the baseline of the patient. And regarding the blood loss and administration of fluids, we have to use colloids along with crystalloids so that the edema is reduced. And also if enough fluids has been administered, we can start the use of vasopressor like phenylephrine or noradrenaline. And the positioning devices has to be appropriately selected, and the head has to be in a neutral position, and it also has to be above the level of the heart. And we have to always ensure that the eyes are not compressed. There is no direct pressure of the eyes. A mirror can be kept below the headrest. And if the eye cervical pin is, if it's applied in cervical surgeries, periodic checking has to be done every 20 minutes. And especially if it's a long surgery, fluid shifts are expected, we can discuss with the surgeon whether they can do it as a staged procedure. And in the post-operative, we have to evaluate visual assessment has to be done. And also if visual loss is there, we have to rule out that any intracranial cause is there, and immediate ophthalmology consultation can be done. There are few studies saying the use of acetazolamide, mannitol, or it can be used, or steroids can be used, but these are all trials. Nothing has been found to be effective to improve the outcome of the patient. So what we can do is to prevent POVL from occurring. So this was a case that was there around 10-12 years ago, where this popular New Zealand football player lost his life because shoulder surgery was done in a sitting position, and the anesthesiologist had stepped out of the OR for a brief time, and he developed post-operative stroke. So if this untoward events happen, this is not acceptable, and we become liable for all this. So this gives the importance of giving importance to positioning, as well as to all the other associated factors of vital parameters during positioning. That's all. Thank you, sir.
Thank you, Dr. Jeeva. So even though we are not directly involved in decision making with related to positioning, we are actually part of the team, when especially when there is a medical legal issues happens. It is basically whenever medical legal issues of complications of position, it is usually the team of comprising of the anesthesiologists and surgeons are most commonly involved in most of the litigations. So we are the one who monitor, we allow the position, we accept the positioning. So it is very important to understand all these details. So all these topics were very nicely and very elaborately discussed. And I thank for giving the opportunity for the ICL, Indian College of Anesthesiologists, for the entire team of Chitra, and had trust on us and give this opportunity. Thank you, B.R.K. sir and Dr. Sanish. Over to you, Sanish.
Okay. Thank you very much. It's been a wonderful session. Very important points discussed throughout this session. I have Dr. Radhakrishnan online. No. Okay, fine. So thank you, Manikandan sir, for arranging this topic and this set of speakers. Dr. Jeeva George as moderator. It's been a fantastic series of descriptions on supine position, lateral position, prone position, and sitting position by Dr. Aswin Ram, Dr. Anjane, Dr. Sreeja, and Dr. Arvin, respectively. I hope all the viewers would have enjoyed the detailing of the presentations and the evidence given, and especially practice points highlighted in this webinar. So thank you for bringing up this ICA session, very effective and significant. To our viewers, I am reminding you again regarding the forthcoming ICA National Conference, which is coming up in November 2 to 5. It's time to meet in a physical meeting. I think we'll wind up the session now. Thanks again to all the speakers and the moderators, especially Manikandan sir. we'll meet next Wednesday with webinar from Narayana Health on acute kidney injury and critical care aspects. So
Thank you, Sanesh.
from ICA. Yes, Radhan sir has joined. Sir,
Thank you. Thank
sir, please.
you. Thanks for winding up and formally. And it was a splendid webinar. And every time our webinar is really proving quality. We had good number of people who attend live. And I'm sure many numbers will be going to see from our archives in the next 2-3 days, because the word is going to spread around that it was a very good webinar. And I, on behalf of Indian College of Anesthesiology, thank Manikandan, Jeeva, and the team members for this excellent performance. And wish you all the very best, and thank you all for joining us. And well, same day next week we will meet with another topic, and that's going to be delivered by Narayan Hridayalaya, Bangalore. Thank you and good night.
Good night.
Thank you so much, sir. Good night.
Thank you so much, everyone, for sharing your valuable insights. Looking forward to host you again on this platform very soon for the next sessions. So with all your permissions, we are signing off for today. Thank you. Good night.
Thank you, Ankita.